We have our first guest speaker of today's session. Before we let him take over on the video, Dr. Rajesh Davda, Physician Executive Board Certified in Internal Medicine, Nephrology, and Clinical Informatics. His experience includes utilization management, physician productivity measurement, quality and total medical cost measurement, performance improvement, clinical informatics, and analytics. He has extensive experience in quality control and management in clinical practice. He has an MBA from Southern Methodist University, Cox School of Business. He is a certified physician with the Executive American College of Physician Executives. So we will ask at this time if we could have Dr. Davda, please get us started. And we welcome you, Doctor.
Thank you. Thank you very much for the introduction. And I hope you can hear me. If you can't, please let me know and we'll figure out something. I do want to thank Carolyn and the staff of Kidney Quest for all their hard work. I've been involved for the last year with them, and it's really been impressive to see them. So thank you for inviting me. I'm going to start sharing my screen. If somebody could let me know, I'm going to assume everybody can see my screen. If you can't, please speak up and let me know. So today we're going to talk about chronic kidney disease and diabetes. We'll start off the talk a little bit about the demographics and things like that for kidney disease. I'll talk a little bit about the pathogenesis of kidney disease, and this is really, the pathogenesis really be directed towards professionals, but then we'll kind of jump into some of the newer things that are going on and some of the newer treatments, and we'll end with really where we were with slowing down disease progression of kidney disease in patients with diabetes and where we are now. And it's pretty impressive to kind of see the changes we've made over the last 30 years. So okay, so the kidney disease is a frequent complication of diabetes. Kidney disease develops in 30% of people with type 1 diabetes and about 40% of people with type 2 diabetes. Now, that's not to say that that many people end up with kidney failure and dialysis, but they do have some degree of kidney disease. And so, and diabetes is the most common cause of kidney disease and dialysis in both developed and developing worlds. And depending on the race in the United States, it can cause between 66 to 86% of kidney failure. So it is the most common cause of kidney failure in the United States. And then really the other important factor I'd like to leave you here with is that it's not just a kidney disease, right? The people who get diabetic kidney disease really have a much higher risk of cardiovascular disease, heart attacks, blood vessel disease, and so strokes. And so we need to focus on that as well. Slide change. So as a public health issue, kidney disease is pretty significant. There's millions of people that are affected by it. It's really expensive on the Medicare budget. I've shown you 2013 data. It's just increased more. It causes a lot of deaths, a lot of heart attacks, and it disproportionately affects African Americans and Hispanics. So although the incidence of end-stage renal disease and kidney is sort of stabilizing out now, we still see lots of people with diabetes and hypertension still end up on dialysis. And really that's the current focus, is is to slow down the progression of people developing kidney disease and dialysis, and to reduce the cardiovascular side impacts. The natural history of kidney disease in diabetics is kind of what I want to go over here. It really hasn't changed over decades. People get high sugars at the top, and then when that occurs, the kidney function actually increases as a compensatory mechanism. And then eventually what happens is you get injury to the kidney. We'll talk about microalbuminuria and macroalbuminuria, which is just protein excretion in the kidney. The kidney function starts to fall. You get hypertension, which contributes more to kidney injury. You get heart disease and infections that contribute more to this. And then eventually, after about 15, 20 years, you get kidney complications. Now, I want to say that this isn't 15 or 20 years after the diagnosis of diabetes. This injury and pattern starts with a lot of people not being diagnosed with diabetes. So screening for diabetes is a recommended therapy or care for everybody. And everybody should have their sugar checked at least annually. If you've never seen this type of a slide, I kind of want to go over it, kind of to show you what actually happens in this process. This is a really old slide. It's been around for a long time. We've known it. So this is the glomerulus on slide A, which is normal. This is the filtration unit within the kidney. If you take a kidney and take a slice of it and look at it under the microscopes, that's what it will look like. Slide B is in the middle to the top is really what starts to happen when you start getting high sugars. You start seeing this really delicate membrane on the left-hand side start to thicken up. So you start getting what we call mesangial thickening, and this is, again, a response to sugar. But not only that, these are blood vessels on a little bit to the right on slide B, and you start seeing the blood vessels themselves start thickening up. And this is kind of the hallmark for diabetic kidney disease. As you progress to slide C, you'll start seeing these nodules kind of start developing where the black arrows are. And then again, to the right, you see the blood vessel kind of thickening up even more. And then slide D down at the bottom on the left is really what we call classic Kimmelston-Wilson disease, which is you get these nodules starting to form. And as you see, the filtration unit is now starting to be damaged. Slide E is really where you start getting vacuoles, and slide F is really now the filtration unit is gone. It's all scarred up and what we call fibrosed over. And really, once you start going down the pathway of C, there's really no, and F, and certainly when you get down to F, there's no reversing this process, right? So once the damage and the scar occurs, you can't really reverse it. So this is, again, for the experts who kind of have seen this, there's a combination of genetics, which is if you have a family history of kidney failure and dialysis, and environmental, which is really uncontrolled sugar and high blood pressure and those sorts of things that eventually lead to diabetes. And then you get a lot of hormonal changes that occur. And the three I sort of want to kind of focus on in this big slide is really the renin-angiotensin system, because we have medicines to kind of deal with that. Control of blood pressure and sugar, because they lead to inflammation and hormones that cause further damage. And then eventually, you start getting down below to what we call renal functional and structural changes, which is the scarring that I showed you guys, and it will eventually cause diabetic kidney disease. This slide is new. It's really important because we've sort of had to re-understand diabetes and kidney disease. We used to think you got kidney disease, both the filtration unit and the tubules in the kidney, and you got protein excretion, and that caused what we call a rise in the filtration unit intraglomerular pressure, or rise in the filtration unit pressures, and we treated that with medicines that reduce that pressure, or ACE inhibitors or ARB agents you might have heard of. And that was our understanding, right? And then now we understand that there's a lot of other things that tend to happen when sugar starts flowing into the tubules of the kidney, and because of your sugar level is high, you get upregulation of what are SGLT2 receptors, and all of this further contributes to continuing damage to the kidneys. And this is where the new medicines and targets have tend to occur. So we had to upgrade our understanding over the last 30 years of this disease. I do want to talk about costs, because that's what I do almost every day, is try to help control costs so that we can all afford health insurance and Medicare will still be around and all those good things. This is an old slide from 2013 from the National Kidney Foundation, but it kind of shows you the point that it's really expensive, right? We spend a lot of money on diabetic kidney disease and kidney disease in general, in older people as well as younger people. This is a slide of how expensive it really is. If you've never seen this, this slide is the cost of Medicare. This Truven Health Market Scan is the cost to private insurance, and as you can see, the cost tends to rise in a few months before dialysis, and then as someone starts dialysis, the costs increase significantly, and then they come back down, but never back down to normal. So they still continue to cost thousands of dollars every month. As we move into diagnosis, one of the newer things I do want to talk about, and I'll show you here, is testing for protein in your urine. But I kind of want to show you, this is again an older slide from the National Kidney Foundation, but it's still true, is that if you look at screening by primary care doctors, the screening is still not completely appropriate. As you can see, if you take a bunch of patients, only very few of them, 10 to 15%, get complete accurate screening. And another 40% are actually screened, tested appropriately, but the primary care physician doesn't establish the diagnosis and doesn't begin the therapy for it or refer the person to a kidney doctor. And then a good 50% of people are not screened at all appropriately. So there's still a lot of gaps that we need to work on and increase awareness with professionals, particularly primary care doctors. And this is where the patients can help us. You know, if you have diabetes, you need to be screened annually for kidney disease. Now, what is screening? Screening traditionally has been the eGFR, and eGFR is basically a formula that we use. We measure your blood creatinine, and then we run it through a formula, and we get a GFR. And because GFR, your actual kidney function, is hard to measure, it's cumbersome, can be done, but it's cumbersome, and it's mostly done in research settings. So it's really considered the best overall index of kidney function. What your kidney function is actually varies with age. If you get older, normally your kidney function will decrease. Your sex, your body size, and all those things tend to occur. And we now know that we were inappropriately adjusting for African American population in this formula. And so after, you know, a good 30 years of inappropriately doing it, we've now moved to doing it appropriately. And if you want to know, if you know your creatinine, if you want to do that, you can just go online. There's lots of these calculators available. Once you know your creatinine, you just plug in the rest of the information in there and it'll give you your kidney function. So it's not secret or magic or anything like that. Hold on just a second. The other thing I sort of want to talk about is the urine albumin and creatinine ratio, which is the screening part. So you get an eGFR, and this is all primary care doctors used to do, but we now know that you have to look at the urine as well. And this is actually a ratio And what they do is they measure the urine protein or albumin, and then they measure the urine creatinine in the lab, and then we just create a ratio. And we divide the albumin by the creatinine and create a ratio. So it allows us to take care of the urine concentrations. And you can do it on a spot urine. You don't have to do it on a 24-hour urine. You can do first morning is preferable, but not necessary. We used to, again, have to make people urinate in a jug for 24 hours, put it in the refrigerator and all that stuff. And what's really cool now is there are home urine screening tools that are available it doesn't give you the urine albumin creatinine ratio, but it tells you if there's protein in your urine. Now, we've been able to do dipstick protein in the urine for a long time. You go to your doctor's office, you can actually go to the drugstore and buy it. And you can do it at home, but it was a little complicated to figure out where it was and if it was important or not. So I want to show you something new, and this is something my company has done recently, and I work for Cigna. And so what we did was we basically used this company called healthy.io, and right now they're only working through insurance companies, and many insurance companies are doing this. And what they do is they have a urine dipstick, which is right here, and they send you a cup and this urine dipstick, and you don't have to measure it by looking at colors or anything like that. Basically, what you do is you dip your urine in it, you put the dipstick on this board, and you take a picture of it on your iPhone. You load the picture up onto an app, and it basically tells you whether you have any protein in there, you have a moderate amount of protein, or you have a very high amount of protein. And it also will send that result to your doctor if you let the app send the result to your doctor. So you get the result, your doctor gets the result, and you can go to the doctor's office and have a conversation and get more tests done if you need to get it done. So we think this is going to be a really important tool going forward where you can do it annually. And if it's normal, then you know that there's no protein in your urine. And if your blood test is normal, then you know you're good. And if it's abnormal, you know you need to get more tests done. So that's really useful to do that. So what are the criteria for kidney disease, right? I kind of want to go over this just a little bit. The first most important thing is it has to be around for 3 months, right? So you can get protein in your urine with fever, with a virus infection, with lots of different things. But so if it's abnormal, you got to be retested, right? So just one test doesn't mean that's all that you have kidney disease. And what you have to have is a kidney GFR or eGFR that's less than 60. You have to have protein in your urine, which is greater than 30. And you got to have some other marker of kidney damage, right? In other words, lots of protein. There are other symptoms and signs that you can have, hypertension, and all of that stuff. And most of the time, this is not really hard to diagnose, right? I mean, the lab tells you the eGFR to your doctor. They can calculate the urine albumin creatinine ratio, like I told you. And, almost everybody will have some other symptoms. So it's not a really hard diagnosis to make. And then once you make the diagnosis, then obviously you have to start thinking about treatment. This is a complicated slide, but I want to kind of show you this because you'll hear the stages of kidney disease, right? And so what we do is we take your GFR, which is on this portion of the slide, and we take your urine protein, and forget all the other numbers in there, but then we come up with a stage, right? Stage 1, 2, 3 is recently been divided into A and B, 4 and 5 is really, and you're end stage and you're on dialysis. And as you can see, your GFR goes from normal and starts going down to less than 15. And so you can get graded on the stage of your kidney disease. And this is really important to know, right? Once your doctor tells you have kidney disease, the question next is, what stage is it? Because what stage is it is determines what treatment you need. And it's important for you to know that in case you end up in the emergency room or something like that, that you tell the doctor there that you have stage 3 kidney disease, because it impacts the treatments that they give you. So I'm going to switch to management, and because we started late, I'm going to try to be on time and try to finish a little bit early. So the management of kidney disease is basically right here, right on this slide: diet and healthy lifestyle, sugar and blood pressure control, ACE inhibitors or ARB agents. And then the newer ones we'll talk about is SGLT2, mineralocorticoid antagonist. And we're going to talk a little bit about lipids because we do want to manage cardiovascular disease. Okay. So this is the triangle, right? This is the pyramid, if you will. Exercise, smoking, weight control are key. Okay. None of this, if you smoke, none of this works, basically, right? We have no medicine that overcomes smoking if you smoke. Exercise, you just got to walk 30 minutes a day. That's kind of the recommendation. You don't, and then weight control, and there are new medicines for weight control if you have severe weight problems. I won't go into them here, but there are newer medications that are available to help lose weight. Sugar control, RAS blockade is ACE inhibitors and other medicines to control your hypertension, and statins. Notice these are first-line drug therapies for diabetics, right? Metformin, SGLT2s, which we're going to talk about, RAS blockade with ACE inhibitors, and statins, right? So if you have diabetic and you have diabetic kidney disease, you should be on all 4 of these. Then we can talk about other diabetic control for people with kidney disease, and we'll talk a little bit about that. And then, the goal here is sugar control, blood pressure control, and cholesterol control. And you reassess every 6 months, okay? So the goals of blood pressure control, this is kind of a little bit of an old slide. I want to show you how things are kind of changing here, right? Is we used to say the goal of blood pressure control and care in kidney disease was to slow down kidney function, decline in kidney function. Blood pressure control and sugar control were key. Blood pressure control, depending on how much protein you had in your urine, but typically less than 130/80. Individualize the targets and use an ACE inhibitor or ARB, right? So this was 2013, 2012. Here's the new ones that came out last year from KDIC, right? KDIC is an organization that produces guidelines for doctors for doing this, right? And so the blood pressure target now is 120. Okay. So if you have chronic kidney disease with or without diabetes, their target is 120. But if you have other conditions going on, you have to sort of individualize the target. Older people, you might not have as much lower of a target because older people don't necessarily tolerate low blood pressures. Same with the people who are very frail. Some people have white coat hypertension and their blood pressure is elevated in the doctor's office, but it's normal at home. So all these things have to be kind of taken into factor. If you have stage 4 and 5 kidney disease, it's pretty hard to get below 120 as your kidney disease advances. Sugar control is also something we have to think about. You may have heard of the hemoglobin A1C, which is a long-term measure of sugar in your blood. We used to think the impact was by blood. All you needed was the blood sugar and the hemoglobin, which is your red blood cell concentration count in general. And you got a hemoglobin A1C. We now know that there are other factors that impact it, right? Whether you have chronic kidney disease, which causes acidosis and these things. Whether you're getting medicines, or whether you're getting medicines to increase your blood count, whether you're taking iron supplements, right? So all these factors influence this, and we have to be mindful of this. The other thing is the target, right? We used to think the target was if you were younger than 65, it was around 7, and if you were older than 65, it was just make sure it's less than 9. But now we know it really depends on lots of other factors, right? Whether you have chronic kidney disease, whether you have other complications, what your life expectancy is. You know, an 86-year-old probably doesn't need a hemoglobin A1C of 6.5. You know, whether you have low sugars and frequent complications of that, right? So all these factors have to be taken in. And so again, we want to individualize the target. Still less than 8, but not a static number that we used to all think about. The other thing I want to sort of bring up is some of you may be using these. These are continuous glucose monitors, right? Which are things you've seen them on television. You plug it in and your iPhone kind of tells you what your sugar is, right? So this is kind of revolutionizing our thinking of diabetes. Again, we used to think about check your fasting sugar in the morning and check your A1C and you were done. Well, the new concept is really what is the time that you spend in normal range, right? Because here's a person on this slide, right? The normal range is described as 70 to 180. Your doctor can kind of adjust that depending on your condition. But look at what happens here, right? Here I am eating breakfast and I get a big spike in my sugar, right? When I eat lunch or dinner, I get a big spike in my sugar. It happens normally. If you have diabetes, you know this happens, right? And you may take insulin or medicines or things like that, right? But what we want to look at is the time that it's normal. So yes, we know you'll get a spike, but if you eat foods that like a piece of fruit or a banana or an orange, it will jump up, but it will come back down very quickly, right? Whereas if you eat a donut, it's going to go up and stay up and then come down very slowly. So the time in range is really going, as you go forward, is going to be the critical factor as we go on. Now, unfortunately, we don't give this out to all diabetic continuous glucose monitors because they're still very expensive. So not everybody can get these, but I think it's something that will happen in the near future. I want to talk about statins or lipid management, right? Everybody should be, who has diabetes and is age 40 to 75, should be on a statin, right? I mean, it's a class 1 up here on the right-hand side, green recommendation. So it doesn't matter what your cholesterol is, right? You should be on a statin. Then what we do is we say, okay, now we have to figure out whether you need to be on a low-dose statin or a high-dose statin, right? And many of you may be taking a medicine called Lipitor. So have to figure out whether you're on 10 milligrams of Lipitor or 40 milligrams of Lipitor. And we do that by assessing your risk, or your cardiovascular risk. And then we do it. If you notice down here, because I'm going to beat up on smoking a little bit, is if you smoke, you're in the high risk category. And you should be, doing that. So again, if you quit smoking, you'll lower your risk. It's very important. But you should be on a statin. And I will tell you that close to 60% of patients are not. So, this is something to think about. This is a graph telling you about cardiovascular disease, right? If you have diabetes, but you don't have chronic kidney disease, your cardiovascular disease of heart failure, strokes, or heart attack is high, but about 40%. If you've got kidney disease, it rises up significantly, right? So, again, we want to manage cardiovascular disease along with the kidney disease, right? Okay, so we're going to continue on this, and I want to talk a little about ACE inhibitors and ARBs. They've been around for about 20 years, right? And I will tell you that still about 50% of people with diabetes and kidney disease are not on these medications. We've been trying to push this for about 20 years. And we still cannot get everybody on these, or 80% of people, which is the target. So you need to be on this, right? And you don't have to worry about this graph, but it's to show you that a lot of doctors will, your potassium could go up a little bit, or your kidney function could go up, go down a little bit. And a lot of doctors will just stop these medications. This particularly occurs if you go into the emergency room or if you go into the hospital. You're on this medication, your primary doctor started you, something else happens, and you get discharged, and the doctors say, well, stop taking these medicines. That's not right, right? We want to assess why this happened, and then even if you need to be off of it for a little while, put you back on it later down the line, okay? Now, why is this important? These are two studies. One, and I'm not going to go over the studies a lot because they've been known for a long time, that if you take these, they provide reduction in kidney disease and protection for type 2 diabetics. Well known, right? The concept, again, I want to talk about is residual function risk, right? So even though, yes, if you take a sugar pill or a placebo and you take the medicine, your kidney risk goes down by 16%. And in this trial, it went down by 20%. But you still have a lot of risk left for developing kidney failure. Okay. And so we're starting to think about more risk, time and range for sugars, time and range for blood pressures in a more sophisticated way rather than just a number. I want to show you that that's going to become really important here in a second. And so if you look at glucose inhibitors, SGLT2 inhibitors, these are medicine that basically, when you take them, you excrete some of the glucose that's instead of reabsorbing it and keeping your glucose higher. So they're used for were designed for reducing sugars, right? And then we found out that they work to slow down progression of kidney disease as well, and they reduce the risk of heart disease. So the current recommendation by KDIC is everybody that has a kidney function that's greater than 20, this is a little bit of an off-label, right? Because doctors, the FDA label says, we haven't tested this in people who have kidney function less than 30, but we now know this is a grade 1A, which is the highest recommendation you can get, right? And there are multiple different types of kidney of SGLT2 inhibitors, and so it's really important that your doctor consider this. And many doctors are not considering this because it's new. These are some studies to kind of show you that it's really important. Excuse me. To reduce your risk of kidney disease, especially the earlier you are. Right, so the earlier the higher your kidney function is, the lower your risk of kidney disease progressing. And I'll show you some slides. It's really impressive at the end. So again, this is a study. Remember, we showed that if you took an ACE inhibitor, your reduction in risk factor was 20%. If you add one of these SGLT2 inhibitors, or if you're taking your reduction in risk is 43%, right? And this was such a phenomenal study that the FDA stopped it in the middle of the trial and approved the drug for this. This was the first trial that came out. Remember, we talked about residual risk. So here's a trial that shows that if you take just the ACE-ARB agent, this is your residual risk, right? You got all this left over. If you add the SGLT2 inhibitors, your residual risk goes down even further. Right? So we want to take care of blood pressure, sugar, and kidney disease to keep reducing your residual risk. This slide kind of shows you, I'm going to skip this slide in the interest of time. Really, how they work, we don't know, right? This is a slide that shows you some hypothesis, but the key is it works on kidneys, hearts, and it's really important. It's a really, really important medicine. The other medicines that are coming out now are what we call mineralocorticoid receptor antagonists. And the one that's out there is called finerenone or Kerendia. Kerendia was approved for diabetic kidney disease. And it's for people who have kidney functions greater than 25 and potassium is normal, right? Because it increases your potassium. Now, again, I'm going to skip this slide in the interest of time, but it works in lots of different mechanisms, works for kidneys, hearts, it reduces inflammation. So lots of different ways this works. And that's how we're now thinking about this. We want to look for drugs that impact lots of different places in the body. You may have heard of mineralocorticoid receptor antagonists, spironolactone, and I can never say this, eplerenone has been around for a long time, right? But they weren't really specific, right? And they had more complications. And now finerenone is what's called a non-steroidal, and it's very high potency, very high selectivity, doesn't have any metabolites, and it's very balanced in the heart and kidney. So this is a significant improvement in diabetic kidney disease. And again, this is a trial that shows you that finerenone is effective. This is another trial that, again, from the Flidio DKD, is that it slows down progression of kidney disease. And a second trial, I want to show you that it does decrease protein excretion, and it does work in heart failure as well. So although not approved for heart failure, we use it in predominantly kidney disease. And I'm going to finish here with the last slide, try to get us back on time a little bit. But this is kind of probably the most important slide I've shown you today. When I started practice, there was no specific therapy for kidney disease. All right, this was before, I'm an old man. This was before captopril and the ACE inhibitors came out. And we used to say, if you had diabetic kidney disease, you came in my office, I could predict your kidney function was going to decrease 10% per year. So if you came into my office with a kidney function of 30, I knew in a couple of years you were going to be on dialysis. There was nothing I could do for you, right, except get you ready. Then the ACE inhibitors, ARBs, came up, and you notice that the kidney function decrease per year went down to about 8. Okay, a little bit of an improvement, but really not significant, right? Then the IDNT trial that I showed you came out where we added neurovascular amlodipine. And we said, oh, wow, now we're starting to make a little bit of an increase, right? We reduced kidney function decrease by 40%. But still not great, right? I mean, if you came in with a kidney function of 30, okay, instead of 2 years being on dialysis, you were going to be on dialysis in 4 years. It's better, but really not great, right? But look at what happens now when we come out with Credence, which is the SGLT2 inhibitors, and Fidelio, which is the trial I showed you on finerenone or Kerendia. We're now getting down to about a 2% decrease in kidney function. So if you came in with a kidney function of 30, we were down to saying, well, maybe I can do something to slow down your kidney function and you won't be on dialysis for 10 years. That's a huge move and a huge improvement these drugs have done. We're headed towards 0, right? So with improved screening, improved testing, knowing your stage of diagnosis, making sure you're on these medicines, including a statin, you really have a significant chance of reducing and slowing down disease progression. And so this is where we're headed these days. And so a huge change. So I will stop here and I will figure out how to stop sharing.
Dr. Davda, if we could real quick, it looks like we have a question that came across. It's from Jessica. She put on here, did Lilly just put a cap on their diabetic meds and their cap was like $25 or $35? And also, what if she doesn't have an iPhone? Can you address either of those?
Yeah, sure. So Lilly did put a cap at $35. It follows the Medicare cap that President Biden just instituted. It's for really commercial patients because Medicare already went to the $35 cap on insulin. I will tell you, most of the insurance companies had already moved to that. My insurance company had already moved to that about a year ago, not costing patients. But now, the cap's helpful for employers and that sort of stuff. But Lilly, it uses insulin, right? So it's for insulin. It's not necessarily these newer types of drugs, right? So insulin's great for sugar control, but as you recall from the pyramid I showed you, you still have to be on these other drugs, right? So I want to kind of emphasize that it's not a replacement. If you don't have an iPhone, obviously, if you have an Android, it can still do the same thing, the home testing. But really, the key is to get your doctor to do it, right? So eventually, if you test yourself at home, you still got to go to the doctor to make sure that you get screened appropriately for protein and creatinine. So my best recommendation to you is, if you have diabetes, you should be seeing your doctor every 3 to 6 months and getting screened annually at the minimum, if not every 6 months, for kidney disease.
Doctor, thank you so much. So wonderful. What a great way to kick off today's event. And we appreciate all your wisdom and guidance. Thank you so much.
Oh, thank you. And I'll see you guys at 2:30 for any other questions on the panel meeting.
Sounds great.